يلا بسم الله. السلام عليكم. My name is Dr. Ayman Al-Ayyubi. I am a consultant of ophthalmology, oculoplastic, in King Fahd Medical City. I used to work here before, and this is an opportunity for me to come back again and give this subspecialty lecture. If you have any question or any comment, I can receive any questions after each part of my lecture finish. My lecture will be divided into 3 parts. Shukran. The first talk about the inoculation, and then evisceration, and last is exentration. As an introduction, inoculation is the definition removal of the globe from the orbit. This could be the oldest operation in ophthalmology. In 1555, Lang was the first one who mentioned having performed a modern inoculation. 1840s in Dublin and Paris, they used anatomic approach for removal of the globe. Mules was the first one who introduced the idea of orbital implants. Of course, it's the most difficult therapeutic decision in ophthalmology. So psychologically, you have to prepare yourself first, and then you know how to approach this news to the patient's family, if a child, or the patient himself, if the patient is an adult. I usually start that, especially if the patient gonna lose one eye because of this surgery. I usually give the good news that he has a good vision in the other eye, and usually a human being, when they lost one eye, it means that they lost only 20% of their visual fields. So they lose only 20%. The difference between you and me is only 20%. If you have a good reserve for that eye, for the safety and taking good care, there will be no difference at all. Cosmetic is available, so prepare yourself that no one will know that you are wearing a prosthetic eye. By this, the patient himself is start to accepting this procedure, accepting the idea of inoculation, and more why we do inoculation. You have to explain the whole reason before you go ahead and do the surgery. So what are the indications for the inoculation? Most important and the most number one indication is an intraocular malignancy. You don't want this intraocular malignancy to be spread or enlarged, and this will be gonna be a disaster for the patient's eyes or the patient's life himself. Another is a blind, painful eye. Cannot be controlled by any medication, this blind, painful eye. You put the patient on anti-glaucoma medication, steroids, all the way that he still have this blind eye. So the only option here, it can go for inoculation. Of course, prevention of sympathetic ophthalmia, that's very rare cause, but it's still happening. More or less, if the patient has a trauma and there is exposed for the uveal tissue, there is a very small incidence for having the sympathetic ophthalmia for the other eye. Other indications could be a severe thusical eye, microphthalmia in a child for enhancing for the bony orbital development in unilateral cases only, and improvement of cosmesis. Most common intraocular malignancy that give us an indicating for inoculation is the choroidal melanoma and, of course, the retinoblastoma. Trauma itself, it can cause causing the inoculation for the patient, especially such in this case who sustained a very severe trauma, indicating the whole globe is almost out, and this is unsalvageable eye. You cannot do anything about it. She has an optic nerve vulgence in the back, and all the globe is almost out. So cannot do anything about this case, only for inoculation. This is, we call it a primary inoculation, or you can do a secondary inoculation to just prevent the sympathetic ophthalmia. If the trauma happened within the first 10 days period, so during this time, you have a chance to do inoculation, and then you may prevent the sympathetic ophthalmia for the other eye. This is the patient's intraoperatively, and this is, we are holding here the optic nerve, the evulsate optic nerve in this side. Blind painful eye, like cases of neovascular glaucoma, uncontrolled, endophthalmitis, severe uveitis, or in cases of cosmesis also. Pre-op evaluation, best if we can go for general anesthesia, but if contraindicated, secondary to any systemic problem for the patient, we can go for local anesthesia under sedation. It can be done through this way. And the surgical techniques, you go for 360-degree conjunctival periotomy. You perform the corneoscleral limbus incision with the scissor here after you release the conjunctiva from the limbus. And then you start to holding the extraocular muscle. You can use the double arm 5/0 Vicryl suture, like in a squint surgery. You need to hold the extraocular muscles, and you need to reserve it, because you need to reattach it again to the implant. After you isolated, you just transected from the insertion side. Then the obliques muscles, you can just transect it. You leave a stump here, 2 to 3 millimeter stump in the medial and lateral rectus muscle. The idea of the stump here is you can pass sutures, the silk suture there, so you can just have a good grip to the globe when you try to inoculate it. As I said here, you can use sutures, or you can use a tooth clamp or a forceps. I usually use sutures. I found it's more controllable. In both sides, I can move the globe. And then you go to just clamp the optic nerve for several minutes, and then you transect it. Usually the easiest way, people thought that the easiest way is you go lateral side because a lot of space, the nose is preventing you to cut the optic nerve, which is vice versa. It's easy to go through the medial side because, as we know, the optic nerve is more medially, and it's easy to just identify it. And then before you cut it, make sure that you have going more posterior in the orbit. The more you go posterior, the more chance that you are cutting more optic nerve from the attachment to the sclera, especially in cases of retinoblastoma. You wanted as much as you can an optic nerve length to prevent extraocular extension. For implants, the implant selection is many. The idea of the implants is only to replace this lost volume, and of course to improve the motility of the prosthesis, maintain cosmetic and symmetrical, to maintain symmetric for the fellow eye. Kinds of implants is a different lectures, but just going through quickly that we have non-integrated and integrated implants, depend on the implant size and wrapping material. The implant, this is the non-integrated implants. Non-integrated, it means that you cannot, the tissue cannot be part of the implant cannot be part of the body. And like this one, we can use like this BMMA implant, which is the most common one, or you can use the silicone implants. The one here in the picture is hydroxyapatite implants. It's made from the coral. The idea of this one is to integrate it with the body and through and become part of the extraocular movement. The patient, when you move right or left, up and down, the prosthesis itself can also move. And that's why we call it a baseball implant, because at the end of the fixing this material, this is of course the donor sclera. You can get it from the eye bank. You have to attach the donor sclera to the implant. Why we do that? Because we can fix the recti muscles to the according to its original insertion. Most important for the implant location and closure. You don't want to do the surgery and later on the patient come to you with the extruded implants. So during the procedure, you have to take care that you have to put the implants very, very posterior to the orbit. You need to close both anterior and posterior tenons, and also avoid the invaginating the conjunctival tissue. All this can lead to extrusion of the implants, or it can cause a conjunctival cyst. You have to keep the pressure at least 3 days. Put the patient on moderate to severe painkiller. Some patients, they need also morphine for at least the first day or second day. It's a very severe, your patient feel severe pain post-operative. And also don't forget that the patient has a fellow eye, so you have to write the patients, give them the prescription, not only advice, go and wear glasses. No, usually patient believe in paper, and you have to give them this prescription that this is for you, safety glasses. You have to write a polycarbonate. Polycarbonate is a material that it's unbreakable, and it's available in all optics shops. The complication for this surgery, removing a wrong eye, it happens, yes, but you have to do, now that's why we are doing time out and make sure about the procedure before patient going for general anesthesia. Ask which eye you want. Don't miss. For some patients, they have bilateral corneal opacity. Some patients have bilateral redness. So don't be so confident that which eye, because it's really catastrophic if you remove the wrong eye. Make sure before you do any surgery, before you touch the patient, try to ask the nurse, look for the file, which eye is this? Under local anesthesia, ask the patients, this is your eye for you want to remove. So make sure that this is your eye that you want to do surgery. Loss of extraocular muscles, it's not a big deal, but you have to be careful during the surgery. You tighten it very well and take many sutures with us. And then orbital hemorrhage. Always these patients are old patients, post-cardiac surgery patient, whatever, diabetic, hypertensive, so they are all in anticoagulants. Make sure that you have to stop these anticoagulants before surgery. Ask the patients if they are taking this medicine for something serious. You have to take a report, medical report from the medical doctor that you can allow to stop this medication before surgery. So you want to prevent the orbital hemorrhage later on. Some early complication, as I said, orbital hemorrhage edema, orbital infection, or the conformer extrusion, or the implants extrusion. A conformer is the plastic patch we put inside between the upper and the lower lid after we finish the surgery, just only to prevent the contracting of the socket. Late complication, you can see in this picture, we have all the late complication. Lax socket, you can see the level of this eye, and the level of this is going down. Enophthalmos, the deepening of the eye and causing backwards, and superior sulcus deformity. This is all can be causes as a late complication. Definitely, any surgery to the eye, it can cause fat atrophy, more in inoculation because you do a lot of manipulation during the surgery, a lot of fat, you are touching it, and God make this fat, just once you touch it, it's atrophied. So by time you have this enophthalmos and sulcus deformity. We raise the question, we have to put a larger implant as much as we can. I usually don't go beyond 20 millimeter size of the implant, because if you do 20 plus the scleral, donor sclera, this is 22. In a child, we can use from 18 also to 20. Rarely we use 22, but in adult, from 20 and 22 size is acceptable. Maybe you will find there is post-operative, the patient has some proptosis in this eye, but definitely by time, this eye will go backwards and the patient has a mild enophthalmos and sulcus deformity. Other late complication is socket contractions, and this is because the conformer, as I said, is becoming earlier out, and the patient doesn't know about it. He thought it may be like a cover, so you have to inform the patient on discharge that in your eye there is a plastic inside your eye, just posterior to your lids. Keep this plastic shield there, don't remove it. If it is out, please put it back again. You have to teach him how to do that, or he can go to any near clinic to do that. Negligence in this matter lead to this stage. So when you want to put a prosthesis later on, you can't because of the contractions of the inferior or posterior fornix. Other complication, implant exposure or extrusion, and wound dehiscence. Any question for inoculation? Very good. For next subject is evisceration. This is removal of only intraocular contents through the opening in the sclera or the cornea. You will leave the optic nerve and the sclera intact with the attached muscles. In 1817, the first recorded evisceration by James Beer. Noise was performed, the routine evisceration procedure. The advantage of this procedure is less disturbance for orbital tissue. It means that less orbital atrophy, and it's better cosmesis. So we always go for evisceration rather than inoculation, unless if there is absolute indication to do inoculation. And definitely, if you tell the patient that your eye is untouchable, we just only remove the contents and it's already blind, he will be accept the procedure more than when you go and tell him we will remove the whole eye. So, as I said, less tendency for the development of enophthalmos and deep superior deformity. Usually, inoculation produces 7 millimeter volume loss, plus 2 to 3 millimeter loss due to the fat atrophy, which is not in evisceration. Less incidence of implant extrusion, and the patient accepted more. Potentially exist of sympathetic ophthalmia. That's the only disadvantage. Or unsuspected intraocular malignancy can be disseminated by the manipulation of intraocular contents. That's why all cases, patients going for surgery, evisceration, or inoculation, you have to have an ultrasound. If you cannot see the posterior ball, you have to do an ultrasound to rule out the intraocular malignancy. If it's not available in your hospital, do CT, MRI. Just you need to do anything to avoid any unexpected surprise during the procedure. You have to do for careful history for the pre-existing ocular disease, along with pre-op examination and ultrasound. It's more difficult with the globe that undergo multiple procedures because there is a lot of adhesions. You need to cut the conjunctival there, and especially our retina fellow that they are so nice with the conjunctiva, so you receive the case with a lot of adhesions. Thumbscale globe, of course, is difficult to do that, but sometimes you have a choice to do the evisceration in the thumbscale globes. Globe injury by trauma with an intact scleral shell, you have to rule out, Usually there is no threat of sympathetic ophthalmia. Blind eye, which is absolute glaucoma, uveitis, and slightly blind eye that has no indication for severe pain or redness, or sometimes with no virulent endophthalmitis, then you go for evisceration. Contraindication, as I said, existence of intraocular tumor or severely fascicle eye. The same like we do for inoculation, but in this time we just do the 360-degree conjunctival periotomy, and then when you remove the cornea also at the limbal here with the Westcott scissor, then you go with the spoon. We call it evisceration spoon. You hold the limbus with the forceps in this side and put it to your side, and you go just a circular method just behind the choroids and the sclera. You will take this as one shot, take it and send it for histopath. The whole contents of the intraocular, you have to send it for histopath. Then you make at 3 and 9 o'clock a small triangular. Why we do that? Just to give a space in case of you don't want to, when you put the implant inside, if you don't do this, you don't want to shred the sclera in every side, so then you need to suture it again. But if you do here, you can just widening the area and allow more room for the implant to go easily inside the globe. People forgot also to do the posterior sclerotomies. I found it's very, very useful for putting a large implant. As I said, the larger implant, the better cosmesis you have. So how to do that? If you have a small sclera, then you have to go posterior from inside. You cut in the 4 quadrants and around the optic nerve. Because what you matter is not the posterior part. What matter is the anterior part. This is the most area that the implant going out. So you need to secure the anterior and even the posterior. If it is make wide, that's no problem. You need the implant to go more posterior. Closure here is very crucial. You have to close in 2 layers, the sclera, and then you have to close the tenon and the conjunctiva. Look for this after evisceration. It looks like a normal eye. So I finish now the last 2 parts of my lecture. Going for the last one is the exentration. Exentration, this is a total removal of the orbital contents, which is indicated in malignant disease, processing originating within the orbit and threatened for extended beyond it. Indication for orbital exentration, we have malignant tumors of the eye and ocular adnexia, malignant tumors extending to the orbit from a cranium or paranasal sinuses. In cases of severe trauma, including the eyelids and the area around it, severe congenital deformities of the eye and the orbit, of course, in severe fungal infection with the mucormycosis, just for this is a life-threatening condition, you have to do exentration. And in cases of severe orbital contractions that you cannot put an implant there, or you can put a prosthesis, so you have to do an exentration to fix the patient with an orbital implant. So this is a case of severe squamous cell carcinoma that involving the fornix. This one you cannot do inoculation or evisceration. You have to take the whole globe with the contents of the orbits around it, and you may reserve the eyelid's skin if there is no involvement of the fornix. This is a severe lacrimal gland adenocarcinoma cases. This, of course, you have to remove all this area and clean it very well, and you can do this as a total exentration. So we have 3 kinds of exentration. We have total, subtotal, and superior exentration. For the total exenteration, when the anterior orbital contents and the lids are involved, then you do total exenteration. For the subtotal, only the anterior orbit, when it's involved, you keep the lids. This is a subtotal exenteration. You split the lids in the subtotal exenteration, removing of the orbital contents and using the remaining of the lids skin for lining the cavity. This is the most common way for doing exenteration, and I'm going to show you how. For the superior exenteration, you involve an en-bloc excision of the orbital contents within the bone or with surrounding structures. In cases of the malignant epithelial tumors, I said, and the lacrimal glands, or bony invasions of the tumor, the en-bloc resection of the orbital contents and the surrounding bone could be maybe necessary. I usually advise during the procedure, if you have a maxillofacial around you or head and neck surgery around you, just to, in case of you are reaching to the dura or just avoiding the attaching the base of the skull, because these are tumors can be very huge. Of course, in these cases, even you need to have a plastic surgery with you to just do a flap, skin flap, large skin flap, because small skin flap cannot help you here. The large skin flap can need to taken either from the patient thigh or from the patient's arm. Malignant epithelial neoplasia originating in the sinuses and nasopharynx may also be require an en-bloc orbital resection along with the excision of the nasopharyngeal and sinus structures. So in exenteration, anatomically, you have to have an idea about these important attachments area. As you know, the orbital septum, the one that you need to take it out during the exenteration, is attached here in the strong attachment in the lateral canthus area, the attachment of the medial canthus here, the trochlea of the superior oblique muscles, also there is an attached inferior orbital fissures and inferior oblique attachment in the lacrimal fossa. During the procedure, be careful from the angular veins, supra orbital bundle here. For this, you need to care about it because of the hemorrhage during the procedure. Anatomically, you need to do a very wide dissection and careful when you do the surgery to prevent the bleeding. This is the, as I said, the subtotal exenteration. When you are sure that the lid is not involved in the tumor, it's early, early cases of squamous cell carcinoma, early cases of just minimal sebaceous cell carcinoma, then you need to reserve the lid. So after you do the you hold the lid and close, you make this circular marking bend, and then you try to dissect the skin from the orbicularis muscles here underneath 360 degree, and then you reach to the orbital rim. Okay, so now you are free. Start to use your freer just only to the periosteal elevator to take the periosteum away from the bone. Avoid the blood vessels and avoid the difficult area. You start always with an easy part and then you keep the difficult area at the end. You don't want to start your surgery with bleeding and uncontrolled maneuvers, so you have to make it at the end. Then you just, when you take the globe out, all the contents, you will have very nice skin here, which used in the upper and the lower lid, and put and just patch the eye. All the skin will attach to the orbital bone posterior. This case is the total exenteration. We take also the lower and the upper eyelid, the whole area. we just marked the orbital rim, as you can see here. You may give local anesthesia, local, just to also prevent bleeding, but be careful. You have to be away from the tumor. You don't want to spread the tumor with the injection, so you can avoid it. And then same idea, you need to attach for the traction suture here in the lid. As you said, this is the idea. You need to go for the total excenteration all the way from the superior orbital rim, inferior orbital rim, all the way posterior to the orbital apex. You can take all the area as en bloc. Carefully, you can go with the periosteum, as I said. Now you can see here the clear orbital, lateral orbital rim here. This is the frontozygomatic suture, you can see. And then carefully, now you cut here the lateral attachments. And then go for the medial attachment. As you can see, make it free. And then you can just easily pull the whole contents of the globe. Same idea with the inoculation. You need to go and just tie the optic nerve for a while with the artery forceps, and then you can just cut it more posterior. Always when you do the surgery, you remove the globe, either evisceration or inoculation. You need to first examine the globe that you remove. It's not being cut prematurely. You can just you cut it during the procedure, so you are not leaving any tissue behind. If you are make sure that you remove the whole globe, all the contents after you examine it, then you examine the area that you are doing. So you don't need to rush and close it immediately. You make sure there is no strange tissue left behind. If you do so, you can just take biopsy and send it for histopath. Make our pathologists busy for a couple of weeks, just for one case. They will hate you later on, no problem, for the sake of the patients. Then this is the picture you will see, only the head of the optic, posterior part of the optic nerve here, and the contents. You can also take, as I said, if you are suspicious, take biopsy, label it, that which area you are taking this biopsy from, and you can put the patch there for almost like just 5 minutes, 10 minutes till its bleeding is stopped. Now, what to do next? As I said, if there is plastic surgery around you, plastic surgeon, they usually are very helpful in this matter. They usually come and do very nice skin graft because you need to cover this area. In the past, I usually keep this one open. Patient come every week for changing the dress, and we do this only, we call it by primary granulation and healing by itself. And then, but it takes up to 3 months till the patient come and recover for fixing for the orbital implants. If you have a very good plastic surgery around you, they can put very nice. So you can see now how it's this healing, primary healing it comes, but this one takes almost more than 3 months till it heal and reach to this stage. But as I said, there's sometimes they do flap or graft, and this will fasten the recovery of the patient, and within 1 month you can send the patient to anaplastology for fixing the orbital implants. This is the case. Patient, they fixing with an orbital implants. They usually either leave it like this with the glue, or they can fixate it with the glasses. Thank you very much. If you have any question or any comment, please, you feel free to do so. Okay. Excellent. Thank you.
إذا كده يا هلا وسهلا، مرحبا دكتور. يا هلا وسهلا، عليكم السلام ورحمة الله وبركاته. يا هلا يا هلا.
طيب.
كويس انه صار رجال عشان نعرف الوضع لو ما جاء
وصلت برضه دكتور، صرت تجيب وصل اصليه من اكثر، بس يبغى الوقت عشان كذا نستغل الوقت. سامحني دكتور، الماك مش كنت في السيستم حقنا اول اتش دي ام اي، اتش دي ام اي كنت في السيستم حقنا يطلع بشاشه بيضاء، ما يطلع بشاشه صغيره، لان الدكتور احنا تسويق ففي
لا هو شاشته، هو شاشته
اي ملاحظات والنوت قصدك؟
انت عندك نوتس سلايدات ولا لا؟ لا يعني بعضهم يكتب تحت نوتس
صحيح.
لا ريبرزنتيشن
بعضهم وفي بعضهم
بس الموجود اللي شايفه
وفي طريقه حفظ السلايد اللي جاي قبل بعد.
دكتور انا نعملها الدكاتره اللي توهم متعودين شغل في خبره كثيره.
طيب الحين يعني كذا تشتغل؟
ايوه خلاص
اول جنبك هذا
جنبي.
بس يتغير
طبعا نحطها اي حيختلف بين الويندوز السلايدات اللي حاطها،
ما نحط
سلايدات خلاص هو الانيميشن
ماشي مالك
أيوة.
حط
خلاص اشغل هذا حتصير حتشتغل الشاشه دي وكل الشاشه اللابتوب ويصير التسجيل كلها شغل، هذا ما حيسجل سامي.
كانت انا شاري قهوه مسكين Angola.
برضه ما كدكتور ما في اي فائده يثبت يعني يدخل ما في اي حاجه يعني خلاص خليه اسمه هو دكتور كذا ولا؟ لا حد يشغل بيطلع سلايد يسوي
لا تستغرب أي شيء يطلع
صادق يا دكتور الرحمن ما شاء الله التغيير هذا الدكتور كله يصير خلاص اي وطي الانوار الصوت حط مدري ايش خليه بعد كنترول ففعلا ايوه كله في عند الدرويه اي فعلا هي تصير هي تصير
غير النبات والالوان
ايوه
14 هذا اللون
ايوه
على الشاشه
اي صح
وفي مصباحات
يا سلام يا سلام مر افعال دكتور لا 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 دكتور لا 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 ان شاء الله لا دكتور والله فيها صراحه
قديم الشغف سوق الكمبيوتر
لا يجي دكتور ما لنا شغل فيه مثلا
ما شدت والله ترى كنت متغير
اي والله دكتور اكثر من نقول
تشتري تنزل
اي You find it?
This one, I don't know if this.
This one? Oh, this is
Two lights.
well, still Mr. That we will play from the HDMI. That's try to the VGA to HDMI to VGA.
خلاص اي ها
So at least we can. After you. Ah, yes.
بس ممكن
Ah, yeah, it is.
This is the one?
Yeah, it is the one.
Thunderbolt.
So,
connect this one.
no.
وين
VGA.
نركب على هذا؟
Where's the VGA?
تحت دكتور
هذا احسن ولا تجيب معي احسن؟
دكتور تشتري معي اصبر
اصفر؟ لا بس انا اقصد يشغل الشاشات الجانبيه.
سامحني دكتور ايش؟
يشغل الشاشات الجانبيه. كلهم سوا؟ هذا الشاشات كلها؟
حبيت بحكي دكتور عشان كده حنسوي تست
اللي هنا
دكتور هذه نظام المرور في الويندوز بتاعها بنتين شاشتين شوف هاي الشاشه بس حنفتح من برا دكتور شلون نسوي المرور ريموت؟ عرفت دكتور المرور ريموت
امال فين الستاند بتاعي؟
طلع عليك اقول
يا دكتور يا دكتور لا بشتغل طب نحط الفلاش احسن
حطينا الفلاش
لا
المشكله ايه في الفيديوهات ولا ايه؟ دكتور الموت معطينا الموت تحت دي طالعه على جنب بس سيبه طيب. ايوه اسمع دكتور بس هتاخذ لها وقت شوي بس لما تعرف ما حتتاخر ان شاء الله.
بس مش مهم البوينت
بسم الله شوي.
ايهاب نعدله ثاني.
ايش اسوي دكتور هنا كونتينيو؟ دكتور يبغى له تعريف بس حطيت الوصله هذه.
كوماند شيفت.
So identification.
وقفت انا ولا إيه؟
Press the key immediately to the right of the shift key.
غير
دكتور
كيبورد.
كنسلها وشوف اشتغل معك اشتغل ما اشتغل خلاص الحمد لله وصلنا.
هي خلاص ما يخالف.
ايوه جرب يا دكتور قلب. بسم الله.
بس خلاص خلاص ما تطلع. بسم الله الرحمن الرحيم. Today our grand round will be in congenital glaucoma. As we know, congenital glaucoma is one of interesting topics actually. And we are happy today to have our associate consultant, Dr. Ihab Al-Sirhi. Dr. Ihab Al-Sirhi is associate consultant, King Saud University, Glaucoma Division. We welcome Dr. Ihab to give us, inshallah, good idea about what happened in congenital glaucoma many years ago and what is recent to be done for these important kids or babies we are dealing with. تفضل دكتور إيهاب.
Assalamu alaikum wa rahmatullah. Good afternoon, everyone. Thank you. Today our presentation, as Professor Isam said, thankful for him, is about congenital glaucoma, mainly about the surgical approach and more specific about the recent advances in surgical treatment of congenital glaucoma. From the title, as you see, 20 years revolution in surgical management of congenital glaucoma, beating the epic 100 years approach, because since the congenital glaucoma being identified as a blinding disease in a very important group of the population, who are the kids, they were all insist in one type of surgery for a very long time. Recently, there is a new modification and a lot of changes happen, at least in the thinking of the people and how can they manage the congenital glaucoma. First of all, just we have to focus a little bit about how people start to understand that there is disease congenital glaucoma. The timeline of this disease, first time being mentioned by Hippocrates 400 years before the Christ, and Celsus and Galen in the first century also noted that there is an enlargement congenitally of the some eyes of some kids. This till that time there is nothing known about something called glaucoma. Berger in 1744 mentioned that there is increased IOB as a reason of it is the reason for the large eye in the children. Later on, Ambrose in 1561 wrote about the ox eyes or bull's eye, and from that started the definition of ophthalmos. And later on, von Moralt in 1869 related the type of glaucoma, as he said the name of hydrophthalmia in a family, but he related that problem in the eye, and the eye became big because of some intraocular inflammation. Not identified that there is increase in the pressure yet. Raab later in 1876 reported that the first demonstration of an obstruction of the iridocorneal angle in congenital glaucoma cases. Later on, von Hebel and Reyes in the late of the 18th century, they wrote about the pathogenicity after the anatomical dissection inside the diseased eye. And they found various malformation in the angle. In 1906, Seefelder and Wolfram, for the first time, they described the pathology of congenital glaucoma as a deterioration of the development of the 7-month gestational age baby or fetus. And they presented the pathological anatomy of congenital glaucoma and compared it with the histology of a normal fetus. In 1907, Trantus could examine the angle in a keratoglobus patient eye with indentation in the limbus. He could see the structure inside the angle of the eye, and he called that action what he did as gonioscopy, but this is without lens, without gonial lens yet. Later on, 1940, Salzmann, who was the first who invented the lens to put on the eye to be able to see the structure in the angle. As you know from the physiology of the eye, because of the phenomena of the internal reflection of the light rays, people cannot see inside the angle of the eye at the edges of behind the limbus. And when they started to modify the lenses, Salzmann in 1940, who was the first who did the goni lens, later on being modified by Koibe and Barkan. Barkan, who is the first who modified a goni lens, which is practically applicable inside the eye to be examined in the OBD clinic. Barkan in 1936, also he described the pathological anatomy in order to correlate that with the finding which he saw in the goni lens examination. He said there is a membrane lining the inside of the angle from Schwalbe's line to the iris. That's including the normal pathway for aqueous efflux out of the eye through the trabecular meshwork. And he reported the presence of mesodermal cider under this membrane. Later on, Wurst in 1966, after about 30 years, he termed that membrane as a Barkan's membrane. But as we said that before that, it is just a remnant of the retention of the normal development of the fetus of 7-month-old. Schaeffer later on, in 1967, described the abnormal mesodermal reticulum in a case with apparent hide insertion of the iris. Later on, some studies done by Anderson, Hansen, and Mewil and Momini, they showed that there is no existence for such a membrane by light or electron microscopy. It's just normal tissue, but have been retained the growth. There is many talk about that. Hansen, many work done to identify more accurately the structure of that tissues and how it affects the physiology of the aqueous drainage outside of the eye. Hansen, Jordan, 1971, they showed that the structure of the angle resemble the stage 200, 240 or 7-month-old of gestation. It's the same as 29 conducted a big study, and he found a special stain there which only found with the normal tissues. Because of our shortage of time, just we will pass these things. However, till that time, there is no specific treatment for the congenital glaucoma. In early 1900, Anderson commented about the congenital glaucoma. He said, "The future of patients with hydrophthalmia is dark, and one seeks in vain for a best operation in the treatment of ophthalmia." The poor prognosis, as we said, of infantile glaucoma changed dramatically in 1938 after the invention of goniolense by Barkan, who started to do his work and apply for the surgery to treat the congenital glaucoma. He invented, actually he modified the invented before surgery, the goniotomy. Goniotomy first done by Dr. De Vincenti's from Italy in 1892, who inside the angle of the iris in the glaucoma. Dr. De Vincent's, he did a few cases and only published his work in a local Italian journal, and it could not be popular because not people around outside of Italy did not know about that work. This thing make the work of goniotomy to stop or to be held for 30 years till Otto Barkan came again and revived the work of Dr. De Vincenti's. He called also the name as interno-trabeculotomy. The name of the goniotomy he called interno-trabeculotomy. And he used his goniolense to do the goniotomy by incising the inside of the angle for 120 degrees. Barkan published his paper on 76 eye. As he mentioned, 66 eyes get normalized regarding the IOB, and only 20 eyes he used the goniolense. The other he didn't use the goniolense because of the corneal edema. Later on, as the same issue about the goniotomy, an endoscopy goniotomy has been modified recently as some sort of ab-interno goniotomy, and this reduced the burden of the corneal edema, and you could do the goniotomy even with dark or cloudy cornea. For many years, the goniotomy remained the classic operation of congenital glaucoma, till a new technique called trabeculectomy ab externo. At that time, not from the angle, not from the aqueous, not from the anterior chamber, but from outside, from the conjunctival side. They opened an opening, dissected the conjunctiva, and reached down to the supposed place of Schlemm canal to open inside the aqueous to make more connection with the aqueous. This first described simultaneously with both Dr. Berrien and Dr. Smith in 1960. The first one who did this, Dr. Berrien, in 1960, March, without the aid of operating microscope at that time, and it was the first external trabeculectomy. He performed on a young girl. She had Marfan syndrome and glaucoma. In the same year, Redmond Smith developed an operation he called nylon filament trabeculotomy. Nylon filament trabeculotomy, where he's inserted a nylon filament inside the Schlemm canal, then he's chiseling wire inside the anterior chamber to open all the trabecular meshwork from inside. The surgical technique of trabeculotomy ab externo was subsequently modified by Harms in 1969, and he is the one who invented his own trabeculotome, the one with two forks, and later on by Danheim and Macpherson. Macpherson he invented the superficial flap of the era, which is very similar to what are we doing now in trabeculotomy surgery. This is the one step forward, as we said, the introduction of trabeculotomy by Berrien and Harmas improved the prognosis of congenital glaucoma very, very, very great. In trabeculotomy, the external approach is used to reach the Schlemm canal, followed by rotation of the probe. That's of course the interior probe in the anterior chamber, thereby opening up 120 degrees of the angle. As you know, this is the Harms trabeculotome. There is one right side, one to the left, You just go from the opening of the Schlemm canal when we after identifying, then rotating the trabeculotomy inside the anterior chamber from this side and again from the other side. Glaucoma filtering surgery, trabeculectomy, was first introduced by Kearns in 1968, and this time he just doing fistulization or externalization of the aqueous to subconjunctival space. Trabeculectomy is not dependent on corneal clarity. A modification of procedure uses 6O Brolin suture or a catheter advanced into Schlemm canal, which can open to 360 degrees of the angle. This is another new modification of that trabeculotomy, and it's just taken the idea from the canaloplasty microcatheter. Later on we'll talk about some more details. Also, the invention of viscocanalostomy. Some people find that we are reached to the Schlemm canal. Why not to inject some viscoelastic material, which is heavy material, to restore again the patency of the Schlemm canal. Sambolisi, he is the first one think that he can do both trabeculotomy and trabeculectomy in the same session in the same eye. He just invented this one in the refractory congenital glaucoma, whereas the previous surgery failed. However, after the invention of the cytotoxic drugs and 5-FU and mitomycin C, a lot of studies that showed that the success rate of the surgery getting more and better after using the mitomycin C in a different concentration and different time according to the study and the situation of the baby, and of course of the status of the tissues like conjunctiva and other tissues. Another invention in the way of managing congenital glaucoma is deep sclerectomy, which was first described by Fyodorov and Kozlov in 1989 and 1990, who are just made modification of the previous one, who is named Kozlov. Kozlov was the first one think that if we can reach to the Schlemm canal and make it patent to the outside space, we can have a better drainage. As we said, Fyodorov and Kozlov modified his work, and as you see here, they just doing just opening the conj and reach to the sclera, identifying where is the Schlemm canal, and opening the Schlemm canal down to the patency to be patent with the aqueous humerus inside the eye. They do this thing about 180 degree around the limbus from the operating field. Later on, Fyodorov, he modified the work of Kozlov, and he just made flap, superficial flap, to guard against the complication which can happen when the pressure get high in the face, to rupture or the hypotonia or something like this. Later on, another work done by Vodox and Marmoud in 1999, they extended the flap, of the superficial flap, inside the descent membrane. The work of the previous doctors, just they stopped at the level of the Schlemm canal. The extra work here now just to dissect more inside the corneal stromal tissue and descent membrane, leaving it intact to have more guarding and give you more percolation. Percolation means more discharge out of the aqueous. The fluid coming more egress outside of the eye when you have this window. Just back to some definition about congenital glaucoma. It's an infrequent disease, as I said, but because and mainly because of inherited developmental defect, representing mostly within the first year of life. And there is many classification of the congenital glaucoma. The classification mainly according to the age of the kid, of the baby. From birth to 1 year, we call it primary congenital glaucoma. From 1 to 3 years, it is or below 4 years, it's an infantile glaucoma. After that, 4 to 5, it's usually called late congenital glaucoma. This is why we make it separated, because after 4 years, there is no more globulus extension. After that, 5 to 40 years, some scientists regard that it is some sort of congenital glaucoma which is present late. We call it juvenile or developmental glaucoma. This is like Quito and Walton and Sambolisi. They think that the sharp age for the differentiate between the globe extension node and globe extension is at 4 years. Glaucoma associated with ocular and systemic malformation belong to another independent group. We call it secondary congenital glaucoma. Of course, because of the reduced aqueous exchange outside of the aqueous, there is collection and increase in the IOB. Chamber angle, the level of the trabecular meshwork, which obstruct the aqueous humor outflow, leading to high intraocular pressure, as I said, and progressive optic nerve damage and other ocular complication. Goniodystogenesis caused by arrested development of the chamber angle. Goniodystogenesis may be severe, and this leading to early presentation of a primary congenital glaucoma, or maybe milder form, and in progressive increased IOB, you have late congenital glaucoma or juvenile glaucoma, which manifests at 5 years or late up to the age of 40 years. When you visualize the angle, there is some comparison between the angle in healthy infant and the angle in the healthy adult. The trabecular meshwork is more lightly pigmented in the infant. Schwalbe line is often less distinct. The uveal meshwork is translucent, so that the junction between the sclerosphere and the ciliary body band often cannot be clearly seen. Regarding the difference between the angle in the normal infant and the angle in the primary congenital glaucoma infant, usually the primary congenital glaucoma gonioscopy showed that the iris insert anteriorly, often on or anterior to the sclerosphere, compared with that way it inserts in the healthy infant angle. Also, the stroma of the peripheral iris is hypoplastic and non-pigmented and has a scalloped appearance. I mean, there is one picture here shows this thing. It's very clear. This is a photo of gonioscopy of the primary congenital glaucoma angle. About the hereditary, most cases are sporadic, non-hereditary, and non-familial. This is according to the Western textbook. They estimate about 10 to 12% family tendency and autosomal recessive hereditary pattern. This is reported by Franchot in 1961 and Duke Elder in 1962. In spite of that, in Middle East, the hereditary cases showed higher percentage. In some study, up to 67% of cases. There is a case from Turkey about wrote by Tamşilik in 2014, showed this percentage. The phenomenon which is striking in the hereditary form of congenital glaucoma, especially in family cases, that both the father and the son, or the parent and the kids, are affected in a form of autosomal recessive mode of inheritance, which is unlikely to happen in other diseases. In 1972, Murin and Morin studied 64 families and concluded that hereditary is multifactorial, both in congenital and in open angle glaucoma. The issue here, why it's different here in the hereditary mode and non-hereditary mode from West country, this may be related to the consanguinity of mode of consanguinity marriage in our region and our relating. See, it's one of the highest area in the world, the family marriage. See, it's above 50% around about that. Maybe here, these countries, Gulf countries, Northeast and Turkey, Iraq, Iran, all of these countries are affected more by congenital glaucoma. This is consistent with the result obtained by Demans in 1981, that in identical twins, both are affected by congenital glaucoma. However, Freud et al. 1977 described the case of a pair of monozygous twin, where only one was glaucomatous and the other was not. That suggests a role of non-genetic factors in their disease. However, the case studied by Journal et al. From 1970-1974 demonstrated that goniodystogenesis is a dominant disease in congenital glaucoma. About epidemiology, in 1994, WHO estimated that about 300,000 children had congenital glaucoma worldwide. And amongst them, there's about 200,000 getting blind because of this disease. The incidence of pediatric glaucoma varies dramatically with race, ethnicity, and level of consanguinity in the community. It is the most frequent cause of early blindness of congenital origin. 50% of cases with blindness in pediatric from glaucoma, and 80% of cases is a bilateral, affect male more than females, about 70 to 60% different from the area. And in some countries it reaches up to 50% equally, but in most of the countries it's about 60 to 70% male more than female. Primary congenital glaucoma also occur in all ethnic groups, as we said, but the incidence of it differs according to the region. It's ranging from one in each to 10,000 to one in each to 20,000 live birth in Western countries, up to one each 2,500 live birth in Middle East, and one in each 1,250 in Rome Gypsus in the population of Slovakia, and in modest in between in one in each 3,300 in the Indian state of Andhra Pradesh. In all of these high incidence population, the consanguinity marriage is very high. In Saudi Arabia and Rome population of Slovakia, primary congenital glaucoma is the most common cause of childhood blindness. How we diagnose a patient with congenital glaucoma? The degree of ocular damage depends on the length of the period between the appearance of the first clinical signs and the surgery, time held the surgery. Neonatal and infantile globe are distinguishable, which result in globe enlargement, which we call this ophthalmos. Most Western textbooks describe the classical triad of symptoms comprising epiphora, photophobia, and blepharospasm, which are attributable to IOP-induced corneal epithelial edema. But in other areas, like our areas and other familial type of glaucoma, like in India, Dr. Chakrabarti, 2009, he conducted a study in a tertiary institution, shows that large eyeball size and hazy eyes or hazy cornea are the more common presenting feature in Indian subcontinent. The same like this in Turkey also, they did a study in 2014 on 311 patients, showed that the main presenting feature was cloudy cornea and ophthalmos, as you see here in the table. Cloudy cornea about 47%, ophthalmos 44%. After that, photophobia and blepharospasm came a percent of 7.5. However, a thorough clinical evaluation is very important to diagnosis of congenital glaucoma. Useful information can be obtained in the outpatient clinic by capturing the child attention. If you have a smart doctor, you should have attention of the baby. You can use the flashlight, blinking light, or gentle jangle of the keys. Usually vision assisted by the age-appropriate methods. If uncooperative patient, mild sedation can be given in the outpatient clinic. Whenever the posterior segment cannot be visualized, it is advisable to perform an ultrasound to rule out posterior segment pathology. In this case, there's problem, and there is also retinal detachment in the surgery. However, EUA is in the same room of the surgery. If the suspect of congenital glaucoma is high, the patient will be scheduled for EUA plus or minus glaucoma surgery. The surgery will be performed there. The IOP, if elevated, this is a very high criteria of diagnosis of congenital glaucoma. And if the time was long enough, this will increase the corneal diameter of the baby, especially if it was asymmetric. This is more significant. Corneal diameter usually greater than 13 millimeter at any age is diagnostic of glaucoma, especially if associated with other signs, or greater than 11.5 at birth. The normal corneal diameter is 9.5 to 10 millimeter at birth and 10 millimeter to 12 millimeter at 2 years old. This is a study conducted by Ellington and Sambulis and others. Other corneal changes which can be happening, like corneal edema. As we said, this corneal edema, severe corneal edema in the right eye. The other eye is not only corneal edema, it's a rare feature. We'll talk about it now. Corneal haziness also, Habs striate, as we see in the first picture up here. It's a horizontal striate of the descemet membrane. Corneal opacities, if the corneal edema became prolonged time, This can lead to fibrosis in the distal membrane and causing corneal scarring and opacity. Rarely, acute hydrops, it's one of the presentation of the congenital glaucoma, and there is very few documented cases. One of them documented in our hospital in King Abdulaziz University Hospital. Like this baby, this is an acute hydrops presentation of his eye. An axial length also is a useful tool to be identified. Any axial length greater than 20 mm at birth, usually regarded as highly suspicious of congenital glaucoma. Normally 16 to 17 mm or 22.5 mm at 1 year old. Gonioscopy also is useful tool if can be done if the cornea was clear enough to be see the structure of the gonio. Regarding iris lens and other parts, if it was pure primary congenital glaucoma, usually they are within normal limit, unless it was secondary congenital glaucoma associated with other deformities or malformation of the iris or the lens. Optic nerve finding in primary congenital glaucoma is simple, those seen usually in adult glaucoma. Cupping in primary congenital glaucoma proceed more rapidly and can be reversible. This is an exciting and interesting feature of the cupping in the congenital glaucoma. It's a reversible cupping disc ratio. However, any cup disc ratio greater than 0.3 also may be indicative of glaucoma. We should also check for peripheral retina if it's possible. And very important point, the anisometropia. There is usually, because the axial length increase with the glaucoma, congenital glaucoma, this will increase the myopic shift of the patient. And if there's any anisometropia and cannot be identified early, even if the successful surgery, may the patient go for amblyopia. Early diagnosis can be made with the family education, especially when they have a positive family history, and the cooperation of the pediatrician. We have to see something about differential diagnosis of congenital glaucoma, corneal edema, or clouding regarding these cases. The main dilemma will come if there is endothelial dystrophy, congenital hereditary dystrophy, the SHID, like this case. This is a SHID case. Cytocyanosis, sclerocornea, like this case, sclerocornea. And rubella keratitis and other causes of corneal edema at the birth. Epiphora also, nasolacrimal duct obstruction, conjunctivitis, or others. And regarding corneal enlargement, this can be normal, like axial myopia, megalocornea, X-linked orthopedic, optic nerve cupping, can be physiologic cupping, can be optic nerve coloboma, optic nerve atrophy, optic nerve hypoplasia. This also can mimic the cupping of the congenital glaucoma. The management is surgery. It is completely different from simple adult glaucoma due to the anatomical and physiological feature of the eyes of the newborn. Early surgical intervention is of prime importance in the management of patient developmental glaucoma or congenital glaucoma. In most patients may have only mild or moderate corneal edema at referral for treatment. This patient may be candidate for goniotomy, which has a high success rate in the Western population. But we have to say here that in other areas of the world like India and Middle East, including Saudi Arabia, Turkey, Palestine, and Egypt, nearly all patients present with clouding, and goniotomy is technically impossible. Regarding goniotomy. In these areas, external trabeculotomy has better chance of success in this area which we mentioned just now. But when initial trabeculotomy has an expected poor success rate as done in the studies and as been shown here in Middle East and around, trabeculotomy may be combined with trabeculectomy as a primary procedure to increase the success rate. There is some studies here showed that what we had mentioned just now. Elder 1993 and 1994, he compared the primary trabeculectomy with combined trabeculotomy and trabeculectomy and found the combined procedure, this means combined TT, combined trabeculectomy and trabeculotomy, showing high success rate and superior for that for the other one, for the single one. In 116 eyes, he did this study. But of course, he did this study in Arabic people. Mulani et al. In 1999 and Al-Hazimi in 1999 here in KKESH used the mitomycin C in primary combined trabeculectomy and reported a high success rate. Al-Hazimi et al. They collected their data in 2004 and published in their study of 820, which was a remarkable point in the management of congenital glaucoma. The interesting thing that they grouped the patient in 3 groups: the mild and moderate and severe congenital glaucoma, severe disease, and they test the 3 types of surgery: goniotomy, trabeculotomy, and combined trabeculotomy, trabeculectomy. And the result was amazing because it's far different from what we used to know from the Western country textbooks. The result in high success rate of 80 to 100 for the mild form of primary congenital glaucoma. In the moderate form of that disease, only 13% for goniotomy and 40% for trabeculotomy, but up to 80% of combined procedure, trabeculotomy, trabeculectomy. The success rate for severe form was 10% only for trabeculotomy. There is no goniotomy in this case because the severe case, the corneal edema is severe. No one can do goniotomy in severe cloudy cornea. So 10% only for trabeculotomy and 70% for the combined procedure, trabeculotomy, trabeculectomy. On the other side of the Riyadh city, in King Abdulaziz there is a study done by Al-Ubidan et al., Prof. Isam also, he there included in the study. And they showed that deep sclerectomy, after done over 143 eyes, had success rate of 82%, which is very promising and high success rate in the congenital glaucoma of the familial type. And why people think about this issue? Because of the safety profile of deep sclerectomy over the trabeculectomy, and it's a very high success rate in adult. Why not to try also in congenital glaucoma? And after tried, they showed very high success rate in this case. This is a study published in 2014, I think. Another study also from Egypt by Bayoum et al., 2012. He is studying combining deep sclerectomy at this time with trabeculotomy, trabeculectomy. He did both in the same eye. And he have comparable results, and up to his study, the time of the surgery being reduced when doing both of them. Gerking et al. Also start to think another way of in trabeculotomy in Western countries by using the microcatheter we used to use in canaloplasty surgery to insert in Schlemm canal 360 degree and then pull the microcatheter inside the eye. And he did his work on both primary cases which have not been operated before and on failed cases, refractory cases. She all in 2017 did the both for primary and refractory and showed a promising result. Recently in Jan 2019, also Mann published his paper about this issue in inserting the micro-assisted catheter to doing the trabeculotomy 360 degrees. As far as I know, also the same procedure is doing here in KH. Regarding this, of course the time is deficient. I don't think we can finish all, but just a quick look. So we have many types for congenital glaucoma surgery. Just in summary, we have the angle surgery like goniotomy and trabeculotomy ab interno. We have the filtering surgeries like trabeculectomy, or when combined with trabeculotomy, it will give high success rate. Filtration surgery also will have deep sclerectomy, which have very high success rate with high safety profile. We have some video, but I think time is not enough to show it. No time? Okay, just we'll pass the surgeries. Also, there is another mode of treating the congenital glaucoma, especially in refractory cases like glaucoma drainage device, like Ahmed valve, Berville valve, or the Orolab valve, whatever available. Lastly, cyclodestructive procedure like CBC and ECB, or the new probe of MB3 of the CBC. Of course, the complication of the glaucoma, as we know, as the all complication of the eye surgery, hyphemia, vitreous-scleroidal detachment, buttonhole, descent detachment, flat chamber, wound leak, hypotony, bleb infection, endophthalmitis. It is more in recent surgery. Of course, endophthalmitis for any case of surgical eye. Medical, it's not our issue here, but just to pass, just to know that alpha-GAN is not allowed to be used in the congenital glaucoma, as the patient can have respiratory suppression. The outcome of the cases, really it can differ the whole life of the patient, and can change the life of the family of the patient. We have many secondary outcomes we can predict, improve the visual acuity, improve the corneal diameter, axial length, and things like that. However, time is not enough to mention everything. We hope to see you again another morning. Thank you for attention.
Thank you very much, Dr. Ehab, for this nice information. We'll allow to open floor only for 2 questions because we have the fellowship celebration today. If you have any question, please. If no question, definitely, as we know, we have some cases, mild cases of congenital glaucoma, and sometimes we are faced with advanced cases of glaucoma, and definitely it depends on the presentation of intraocular pressure and the corneal severity of haziness. Any type of surgery can be done for mild cases can definitely succeed. The problem we are facing, because majority of our patients usually present with severe haziness cornea and the corneal scarring. Sometimes you have no view. Some of the patients also presented with anterior segment dysgenesis. Don't be surprised that he mentioned cyclophotocoagulation. I received one patient who has no anterior chamber at all, iris is attached to the cornea. With UBM, there is nothing inside the globe, the iris completely attached, and we are not able to do for him glaucoma surgery. Sometimes you are forced to do an example of cyclophotocoagulation. Thank you very much, Dr. Ehab, for this nice presentation, and we will start our ceremony, please.
قصيرة؟ قصير شوي. لحظة بيطلع يمين. بيطلع يمين. أنا بحبها. في أحد. أوكي. يعني مو أنا اللي بغير. طيب شو بليز تأكدي من مين متأكد إيه؟ أنا لطيفة كانت على أساس كذا. ما أعرف. أوكي يسلمك.
later on. One test. One test. Who will use it?
خفض النور. النور خفض.
تبغى الليزر؟
النور اللي هنا يخفض شوي.
النور اول ما تبدا ناخذ لفه البدايه النور ما تبدا.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. نرحب بكم جميعا في حفل تخرج أطباء زمالة مستشفى الملك خالد التخصصي للعيون. Good afternoon to you all. It is an honor to welcome you to the 2019 King Khalid Eye Specialized Fellowship graduation ceremony. We would like to start with the welcoming remarks presented by Dr. Sami Shahwan, Fellowship and Residency Training Director.
Assalamu alaikum wa rahmatullah. Good afternoon, everybody. His Excellency Dr. Abdulaziz Al-Rajhi, Chief Executive Officer, Dr. Salih Al-Misfir, Chief Medical Officer, Dr. Deepak Edward, Chief Research and Training Officer, Division Chairman, Department Heads, colleagues, distinguished graduates, and parents, ladies and gentlemen. On behalf of the Fellowship and Residency Program at King Khalid Eye Specialist Hospital, it's an honor and privilege to welcome you all to the 2019 Fellowship Program graduation. To the fellow graduate of 2019, let me be the first to congratulate you for all dedication, hardship, and great efforts and success as you completed your 2-year fellowship program. We are truly proud of you as you succeed as a physician and teachers. Your outstanding performance is a proof to the balanced clinical experience and academic strength that you gain in the fellowship program. Please continue to enhance your knowledge and skills to contribute to the prevention and treatment and diagnosis of the eye disease, as well as acquired as a skills in education and research. In our journey toward this fellowship training, I would like to express my profound gratitude to Dr. Al-Rajhi for his generous support and encouragement and guidance. In addition, I would like to acknowledge Dr. Salih Al-Misfir and Dr. Deepak Edward and the division chairman, faculty and staff for their untiring support to the fellows in their respective specialization.
أنا معايا بس أبغى أنزل حق عمار.
I would like also to thank Dr. Al-Darrab, Chief Fellow, and Dr. Al-Wayfir, Associate Chief Fellow,
ما ينزل ها؟
and all the fellows coordinators. We appreciate all your hard work and cooperation with your colleagues. To the family and friends, thank you for your presence and solidarity on this significant event. Once again, my sincere congratulations to my dear fellows for your achievements and best wishes to all of you. Thank you. And just let me show you how many graduates since we started KKESH and some statistics about our achievement. So since the start of KKESH from 1988 to 2019, we graduated 461 trainees. 2009 they finished the residency and fellowship, and also 139 who did fellowship only, a total of 348 graduate from the fellowship. And also we graduated 130 residents who did their fellowship outside. Total of GCC resident and fellows graduated from KKESH, we had 37 resident and fellow graduated from the KKESH program out of 461. And if we look to the number of Saudi consultant and fellows and register at the Saudi Commission for Health Specialty, From 1988 to 2019, we have 528 Saudi consultant and fellow. Out of these, 424 account of 80% trained in KKH, where are the 104, 19% graduated elsewhere. So I'll take you to our achievement and statistics for every department. In glaucoma department, we had graduated 4 fellows. They finished 17 research projects, and they participated in seven community awareness, and also they presented 19 lectures, and they attended 14 conferences. A total of surgery done by fellows 512 as a main surgeon. For cornea and external eye disease, fellows, we had 6 fellows graduated today. They completed 15 projects. They participated in 7 community awareness. They presented 15 lectures, and they attended 19 conferences, a total of number of surgery, 1,166. For pediatric ophthalmology and strabismus, we graduated 3 fellows. They finished 7 projects. They participated in 1 community awareness, and they presented 10 lectures, and they attended 16 conferences, a total of surgery 768 performed by the fellow. For retina fellow statistics, we graduated 6 fellows. They had 12 projects completed by the fellow. They participated in 5 community awareness, and they presented 17 lectures, conference attended 15, total of surgery 1,082. So overall statistics for all our fellows, we had 20 fellows today being graduated. They completed 57 projects. They participated in 20 community awareness activities. They presented 64 lectures, and they attended 66 conferences. Total surgery done by all our fellows as a main surgeon, 3,779. Thank you.
Thank you, Dr. Shahwan. Now, on behalf of the graduate fellows, I would like to ask Dr. Abdurrahman Darab to give the chief fellow to give a short speech.
Assalamu alaikum. This speech will be in English, then in Arabic. أبلقي الكلمة باللغة الإنجليزية بعد كذا بلقيها باللغة العربية. Our dear families, respected Chief Officer Dr. Abdulaziz Al-Rajhi, respected Chief Medical Officer Dr. Salih Al-Misfer, respected Director of Fellowship and Residency Program Dr. Sami Shahwan, respected staff one by one, and my dear fellows, Assalamu alaikum wa rahmatullahi wa barakatuh, and warm greetings to all of you. First of all, I would like to thank each one of you for gathering here to celebrate our graduation. This grand event has been organized by the Fellowship Office, which I must say they were very helpful throughout our fellowship, represented by Dr. Sami Shahwan and by Ms. Latifa Al-Hazmi. I feel honored to represent the fellows by giving me this opportunity to deliver this speech, as we have got such a grand event, our graduation. So thank you. I'm standing here with mixed emotions, and I am sure all my fellow colleagues might be feeling the same way. While we're excited about entering the new world, we also have some apprehension, as we are not aware what has the future in store for us. Having said that, I also remember our teachers, our dear consultants. They always used to say that we should not think about our future. We should, in fact, only be prepared for the future and do well in the present to secure our future. We would always remember this precious lesson of yours. To my junior colleagues, I would like to say that you all have joined of academic, clinical, and surgical knowledge. Special thanks to our dear consultants who helped us patiently to pass and master them by refining our skills and generously sharing their knowledge, in which without that we definitely would not reach our goal, our success. Here we have also learned practical lessons of life. One of the best things about our hospital has been the charity works that residents and fellows are inspired to do, such as seeing patients and helping other cities surgically, participating in social events related to ophthalmology, as well as participating in international campaigns. I must say, through these acts, we learned such important lessons of life in such fun and pleasurable way. We also promise we would always live by the spirit of the precious knowledge we have acquired here and would inspire everyone to follow these basic rules of life. In the end, I would like to thank each and every staff at this hospital, the CEO, the CMO, the fellowship office, the consultants, the nurses, the specialists and technicians, the residents and fellows. For everyone has been great throughout our days at the hospital. I would end my speech with the promise that we would keep in touch with most of you. I would wish all the luck to the graduating fellows in their next step. In the end, I would say that always believe in yourself and do not lose heart, even if you fail. Thank you, and all the very best to everyone. أهالينا الأعزاء، الرئيس التنفيذي المحترم الدكتور عبد العزيز الراجحي، رئيس الخدمات الطبية المحترم الدكتور صالح المسفر، مدير برنامج الزمالة المحترم الدكتور سامي الشهوان، الطاقم الطبي والإداري المحترمون، وزملائي أطباء الزمالة الأعزاء. السلام عليكم ورحمة الله وبركاته، وتحية طيبة لكم جميعا. بادئ ذي بدء، أود أن أشكر كل منكم على الحضور ومشاركتنا هذا الاحتفال، والذي تم تنظيمه بالتعاون مع مكتب الزمالة، والذي يجب أن يشكر لما قدمه لنا من خدمات وتسهيلات طوال فترة الزمالة، متمثلا بالدكتور سامي الشهوان والأستاذة لطيفة الحازمي. أشعر بالفخر والاعتزاز لتمثيل زملائي أطباء الزمالة بأنني قد أعطيت هذه الفرصة لإلقاء هذه الكلمة في هذا الحدث الكبير، تخرجنا، فشكرا لكم. أقف هنا بمزيج من المشاعر، متأكدة من أن جميع زملائي يشعرون بنفس الشعور، بينما نحن متحمسون لدخول العالم الجديد، فقد يراودنا قليلا من القلق لما يخبئه لنا المستقبل. ولكن أتذكر أيضا أساتذتنا الكرام كانوا دائما يقولون إننا يجب ألا نفكر كثيرا في المستقبل. في الواقع يجب أن نستعد له بالعمل وتحقيق الأهداف في الحاضر، فتقطف الثمار في المستقبل. إلى زملائي من بدأوا التخصص، أود أن أقول أنكم انضممتم إلى مستشفى مرموق جدا، فهو أحد أشهر المستشفيات في المنطقة، والعديد من أطباء الزمالة وأطباء زمالة التخصص الدقيق يسعون إلى الانضمام إليه. هنا تعلمنا المهارات الأكاديمية والإكلينيكية والجراحية، وذلك بفضل من الله ثم استشاريين الأعزاء الذين ساعدونا وصبروا علينا كثيرا حتى أتقناها بنجاح، وذلك من خلال تحسين مهاراتنا وإعطائنا علمهم وخبراتهم، والتي بدونها بكل تأكيد ولن نصل لما نحن عليه الآن، فكل الشكر والتقدير لهم. هنا أيضا تعلمنا دروسا عملية في الحياة. من أفضل الأشياء هنا هي الأعمال الخيرية كفحص المرضى ومساعدة المدن الأخرى جراحيا، والمشاركة في الأيام العالمية للعيون، بالإضافة إلى المشاركة في الحملات الخارجية. في النهاية أود أن أشكر كل موظف في هذا المستشفى، الرئيس التنفيذي والمدير الطبي ومكتب الزمالة والاستشاريين والممرضين والأخصائيين والفنيين وأطباء الزمالة، وأتمنى كل التوفيق والسداد للزملاء المتخرجين في خطوتهم القادمة. شكرا لكم جميعا.
Thank you, Dr. Al-Dharrab. I would like to invite Dr. Abdulaziz Al-Rajhi, Chief Executive Officer, King Khalid Eye Specialized Hospital, to chair his remarks.
بسم الله الرحمن الرحيم. السلام عليكم جميعا. Good afternoon, everyone. Dear colleagues and family of KKESH and friends, welcome to this very important memorial event for all of us. This is the time where we see our colleagues graduate after a 2-year-long training in their subspecialties. It has been a great honor and privilege to have the 24th batch of fellows at KKESH and to have them graduate this year. We have 20 of them graduating, and one is from our beloved Kuwait. I know that we were in medical school, we used to think the minute I get my medical degree, I've made it, I'm a doctor now. And then you discover that you're still way far ahead. And then you say, I'll finish my 3rd years of residency, and by then I'll be an ophthalmologist, and that's the end of my suffering. Only to discover that you are not there yet, and you still have to subspecialize. And now that you have subspecialized and finished, you are truly at your first steps of your professional career. Now you are in your first few steps that will take you to the position that you think is the top, which is being a consultant. But then you discover you're still at your first baby steps. For a long time, you've been called trainees. From now on, you'll be trainers. This does not mean that you still don't have to learn and be educated and be humbled by the experiences of others. Don't think that you've reached the summit yet. You still have to fight and struggle to be the best of yourself. I will always say, don't focus on competing with others, but focus with yourself, competing with yourself. You have to be the best version of you every single day. During this journey that you had through your residency and fellowship, you've met lots of people. Some of them you've respected, and some of them left you with some negative memories and things that you thought could have been better. Well, you should learn from both of them. Those that have done things properly and in the right way, do like them. And those who have not reached the level that they should have, learn from their mistakes and make sure that you don't repeat them. Always remember why you are an ophthalmologist. Making money is important. Prestige within your community and your family is important, but this is not, or at least I hope, this is not why you became an ophthalmologist. You became an ophthalmologist to help your patients. So your focus is on them, not on the working hours, not on the financial rewards, not on the prestige or where you sit on a table or how people talk to you. It's how you serve the people around you, people in need. And I'm sure all of you know the satisfaction that you get from a grateful patient or from a patient that you have helped see and changed his whole life, and that its value is much bigger and higher than any other financial reward that you might get from anywhere. Remember that any word or any comment that you make to your patients have a major effect. Remember that your residents and your future fellows will learn from you, will try to do what you do. So try to be the best example of what you should be. Be humbled no matter how big you become. Always be humbled. Always remember there are people that you can learn from, and always remember that you're treating human beings and not just patients or medical files or records or cases that you see. Eye contact with patients is very important. Now we're very proud. KKESH, for example, have reached level 7 in HIMSS medical records, and this is the peak, at least in our profession, in terms of the quality and the integration with the medical record system. But as you all know, this has decreased our interaction with our patients, because now we have to waste more time in writing notes and clicking and looking for tabs and adding notes than talking to patients. Please don't forget why you're there. The patient needs you to listen to you. You are the ones that made the reputation of this hospital. We keep on saying KKESH is a culture. It's not just a hospital. And we hope that you will continue that culture and spread it elsewhere, and not only KKESH and also beyond KKESH. Your relationship with KKESH family and KKESH as an institution does not end here. I'd like you still to be part of this institution. We will definitely keep in touch with you. We would like you to join us in all our activities. Help us to improve the services that we have. If you ever have any ideas that will improve the services, and I can tell you and assure you that this will always be your home, whether you're here as fellows, residents, consultants, or you're working somewhere else. All our facilities will always be at your disposal, and we all are still your bigger and a more extended family. I'm happy to have you here on this very important and joyful day. I'm even happier to see your family members here, and I'm sure they're very proud of you. Don't forget them. They are the ones that probably suffered a little bit more than you. And you neglected, many of you probably have neglected many of their needs and missed many of their activities and social lives because you had to cover your responsibilities in here. So also to them, we extend our gratitude and we thank them for allowing you to do your job in the best way that you've done it. Finally, I wish you all the best and good luck. Thank you very much.
Thank you, Dr. Al-Rajhi. Now, I would like to ask Dr. Al-Rajhi, Dr. Misfir, and Dr. Shahwan to be on the stage to present the graduation certificates. Before we start presenting, the graduates are welcome to ask their family members to be on stage when receiving the certificates if they wish. We will begin with the glaucoma division, and at this time, I would like to ask Dr. Hud Al-Awela to kindly, Chairman of Glaucoma Division, come forward, please. The glaucoma fellows are Dr. Abdurrahman Ibrahim Al-Darrab, there is an appreciation certificate to Chief Fellow Dr. Al-Darrab as well. Dr. Muhannad Ahmed Al-Qurashi. There is an appreciation certificate to Glaucoma Fellow Coordinator as well, Dr. Al-Qurashi. دكتورة أشواق ربيع العبيري. دكتورة نجلاء أمير حفيظ الله. Thank you, Dr. Al-Awela. I would like to kindly ask Dr. Samar Suwailim, Chairman, Anterior Segment Division, to kindly come to the stage. The Cornea, External Eye Disease and Refractive Surgery Fellows are Dr. Faisal Nasser Al-Dosiri. There is an appreciation certificate to Cornea Fellow Coordinator Dr. Al-Dosiri as well. دكتورة رفاه طارق فيرق. There is an appreciation certificate to Cornea Fellow Coordinator Dr. Fayraq as well. دكتور محمد سليمان العمرو. دكتورة إيمان ضيف الله البلوي. دكتورة دانيا فوزي الدهان. دكتورة روان صالح بن شبيب. Thank you, Dr. Swailem. I would like to ask Dr. Osama Sheikh, Chairman, Oculoplastic Division, to come kindly to the stage. The Oculoplastic and Orbit Fellow is Dr. Mohammed Saleh Al-Rajih. There is an appreciation certificate to Oculoplastic and Orbit Fellow, the coordinator, Dr. Al-Rajih. Thank you, Dr. Osama. I would like to ask Dr. Mohammed Al-Shamrani, Chairman, Pediatric Ophthalmology Division, to come kindly forward. The Pediatric Ophthalmology and Strabismus Fellows are Dr. Saad Mohammed Al-Dhiabi. There is an appreciation certificate to Pediatric Fellow Coordinator, Dr. Al-Dhiabi. دكتورة الجوهرة طلال الدامري. دكتورة هديل مانع اليامي. Thank you, Dr. Shamrani. I would like to ask Dr. Marco Mora, Chairman, Retina Division, to kindly come to the stage. The Vitreoretinal Disease and Surgery Division Fellows are Dr. Khalid Hassan Allam. There is an appreciation certificate to Retina Fellow Coordinator Dr. Allam. دكتور عثمان جار الله الجار الله. دكتور عبد الكريم عبد الله الخراشي. دكتور عبد الله عبد الرحمن المرشود. دكتور أحمد عبد العزيز المهيلب. دكتور وائل عبد الرحمن سكران. Thank you, Dr. Mora. Congratulations to all of our graduates. Thank you all for joining us on this memorable occasion. Yes. We would like to invite the new graduates and division chiefs to join those on the stage for the group photo. اوكي.
انت سهل.
ايوه.
كيف حالك ساره؟ انا فيصل. كلمتك ذكرى من زمان؟ على مؤتمر 35 عام؟
اي سوري معليش.
ترى ما كلمتك لانه بدلوا البلان وطلبوا اكثر من رئيس يتكلم. وقتها. اي لا بس حبيت اعرف. لا
انا جدا.
لا انا ما نسيت.
All KKESH consultants, please, would you come, staff, come to the front?
Could Can I have your attention for a few seconds, everyone? Excuse me. Excuse Excuse me? Just a little. السلام عليكم. معليش بس لو اخذ من وقتكم دقيقة. دكتور ضراب عنده بس كلمة يبغى يقولها على خير.
السلام عليكم. بس قبل لا نطلع من المستشفى يعني ودنا نعطي الدكتور سامي والأستاذة لطيفة الحازمي هدايا تذكارية يذكرونا فيها.
في صورة ثانية مع لطيفة لطيفة
السلام عليكم. دقيقة واحدة من وقتكم. في البداية أحب أبارك لكافة زملائي الخريجين في كافة التخصصات. ودي أستغل هذه الفرصة بس لأن كافة زملائي أطباء الزمالة ودي أن نشكر الدكتور عبد الرحمن الضراب ونودي نقدم له هدية بسيطة ما تمثل الجهد اللي تعبه معانا ولكن فقط هذا جزء قليل من قدره عندنا.
We are
هلا والله.
عبد الرحمن كيف حالك؟ الله يعطيك العافيه. الف مبروك.
شلون الحفل؟
لا ممتاز ممتاز ما شاء الله تبارك الله. والاعداد البرزنتيشن كان صراحه مبسم. ها ما شاء الله تبارك الله يعني
مجهود سنه.
قول له بالله محمد
مبسم صراحه.
جلوكوما ديفيجن.
لا ارفع صوتك كذا جلوكوما
ديفيجن. جلوكوما ديفيجن. مين باقي؟ مين باقي؟ والله
كلنا طلعنا بالصوت.
لو سمحتوا في الكيكه برا، لو الجميع يشارك في تقطيعها.
المفروض كلنا نجي خلاص